Dear friends, dear colleagues, dear attendees, today I'll be talking about papillomatosis, but for the first minutes of my talk, I will reserve some time for Phoniatrics and Union of European Phoniatricians. As you well know, Phoniatrics is the medical specialty of voice, speech, language, hearing, and swallowing disorders. In 1971, these four professors, Dushanchevich, Petar Bizalski, Gerhard Kittel, and Oskar Schindler, come together to establish the Union of European Phoniatricians. At the 50th year, we were again in Belgrade to celebrate the 50th anniversary of our union. We were so happy to see each other. It was just after the COVID days, so we enjoyed being together. Although we call ourselves the Union of European Phoniatricians, UEP is an international society with more than 500 medical doctor members in 52 countries today. And our last Congress was in Antalya in 2023, and we were more than 400 participants there, and it was a real family gathering. Our next gathering, our next Congress, will be in beautiful Prague. The president of this meeting is my dear friend Jan Bušek, so we will be very happy to have you with us in Prague in 2025. Now let's focus on papillomatosis. Papillomatosis is a costly benign airway neoplasm. It's challenging, it's capricious, and it has potential for morbid consequences. It's mainly formed by two types of human papillomavirus, type 6 and type 11, but sometimes high-risk types may be related as well. This is actually a disease of the epithelium of the respiratory tract. Here we have two nice pictures, optical coherence tomographies of one healthy and an infected young boy. Here you see that at the infected part, the basement membrane is pushed and there is epithelial hyperplasia. The lamina propria of the vocal fold is squeezed between the basement membrane and the vocalis muscle. The characteristic view of recurrent respiratory papillomas is the exophytic papillomas, as you see here at the vocal folds. Although we see this disease very rarely, it is estimated that around 75% of the population is infected with the virus at least once at their lifetimes. And studies show us that even in healthy individuals, that virus is seen sometimes between 2 to 20% in oral healthy mucosa and 1 to 10% at the laryngeal healthy mucosa. The most common location of papillomas is vocal folds in the larynx, especially the membranous vocal folds. And when we see recurrences, we usually see those recurrences adjacent to the previous ones. And when we have a biopsy of the epithelium, we both see papillomas at the pathological sites and also at the normal appearing sites. The clinical presentation is so changeable. Sometimes we see spontaneous remissions, and sometimes we see real aggressive growth that compromises the airway. So the clinical presentation may change from a small voice disturbance to a great airway problem. According to the age of diagnosis, we have the juvenile onset form and the adult onset form, but new studies show us that there are three peaks during the lifetime at the first, fourth, and seventh decades of life. The examination and diagnosis is, of course, easy by rigid exam, just by rigid laryngoscopy or by stroboscopy. But what I like, especially in adult patient, is that to make a thorough airway exam with a flexible endoscope, because sometimes, as you see here, we can also see papillomas, not just at the vocal folds, but at the whole airway, here at the nasopharynx and at the posterior part of the uvula, if you can see here, and of course, at the laryngeal inlet at the whole airway. And if you have the biological filters like MBI or iScan, of course, it's easier to diagnose the borders of the lesion and to be able to separate it from the normal appearing mucosa. And of course, you can see the margins of the pathology even much better. The juvenile onset form is formed by a transmission from an infected mother during pregnancy or during birth. At least 1% of the infants that are born to mothers with anogenital warts have this unwanted outcome. With cesarean section births, this can be decreased, and the juvenile onset form is usually more aggressive than the adult onset form. At the juvenile onset form, lung involvement, lower respiratory tract involvement, and malignant transformations are seen much more common than the adult onset form. And if you look at the HPV types, we see that infection with an HPV-11 is more troublesome than HPV-6. For adult onset form, of course, HPV is necessary, but there may be some cofactors related with the clinical appearance of papillomas in adult patients, like laryngopharyngeal reflux, pepsin, viruses like Epstein-Barr virus. We know that Epstein-Barr is related with oropharyngeal and head and neck cancers, or other viruses may be cofactors for the pathophysiology of papillomas in adult patients. The histopathological appearance of papillomas is so pathognomonic. There is a central fibrovascular core, and around that fibrovascular core, there is epithelial hyperplasia. When we look at the pattern of the vessels on the vocal folds, the pattern of the papillomas are similar to the ones with precancerous lesions and cancers, what we call the type 5 pattern. But with high definition imaging, we can see that these intrapapillary capillary loops are more symmetrical, and there are differences then from the malignancies or precancerous lesions. But differential diagnosis is sometimes not so easy. We should emphasize that this disease is preventable with vaccination. Of course, the vaccine is most effective before facing the virus. So before becoming sexually active, the recommendations of the United States Center for Disease Control is vaccinating children at their ages 11 to 12. And the FDA indicational approval is so expanded, beginning from the age 9 to elderly. Today, we are using the 9-valent vaccine, which is protecting against 9 types of the HPV virus. And of course, this is beneficial for not only respiratory papillomatosis, but also for the benign and malignant diseases of the anogenital tract, and also for the malignancies of the oropharynx and head and neck. For this purpose, WHO, the World Health Organization, is targeting to immunize children, especially girls, by the age of their 15, at least 90% until 2030. So they are in communication with 194 countries, and today in 135 countries, it is either just for female children or for both sexes in the national immunization program of those countries. When we want to manage papillomas, we don't have a specific, definite magical cure yet. What we are trying to do is that to protect the voice quality, to maintain airway patency, to kindly protect the healthy tissue as much as possible. For this purpose, we can use cold instruments, lasers, microdebriders, or coblation, but the best practice is to protect the healthy tissue as much as possible. If we are using lasers, we have 2 different types of lasers. First group is the cutting ablating lasers, and the second one are the photoangiolytic lasers. For the cutting ablators, we have carbon dioxide or thulium, and photoangiolytic lasers, we were using pulse dye laser and KTP, but today, most commonly used one is the blue laser. You may use those lasers in the office or in the OR, but if you already have a histological diagnosis, if the pathology is not bulky, if your patient is complying to a procedure under local anesthesia, of course, it has advantages to use this in the office. I mean, in the OR and in the office, you have advantages and disadvantages to use the lasers. But sometimes excising or using lasers on those pathologies may not be enough, and there is a need for adjuvant treatments. For an indication, for indications of adjuvant treatment, we may talk about rapid growing lesions leading to airway obstruction. There is a presence of, if there is a presence of tracheotomy, if we need surgeries, let's say more than 4 or 5 times in a year, if the age of diagnosis is too early, and as a relative indication, we can talk about a young professional with high vocal demand. The medications that are used as adjuvant treatments are numerous. Most of the literature is filled with treatments with interferon, which is not used much anymore. The second most popular one was cidofovir, especially its intralesional administration, and of course its systemic use were emphasized at the studies. Today, we are reading more and more papers on the use of bevacizumab as an adjuvant treatment in papillomatosis. Actually, it's an old drug. It was FDA approved in 2004 for metastatic colon cancer. It has anti-angiogenic properties, which is very important for a vascular lesion like papilloma. And each and every day, we are seeing new studies with a systemic or intralesional use with lower and lower doses. We can also use vaccination as an adjuvant treatment, although, as I said, it's nice to use it before facing the pathology. It is still useful to use it because when we vaccinate our patients, we see that the intersurgical interval is increasing and the aggressivity of the disease is decreasing. Sometimes dealing with papillomas becomes so troublesome. Here you see one of my patients. Although I am under microscope, the suspension of the patient is so difficult that I also have the flexible endoscope with a channel in my hand. So sometimes it's even difficult to reach to those papillomas. It's troublesome for the clinician or the surgeon. But we should always keep in our minds that this is both physically and psychologically a real burden for the quality of life of our patients. There is disturbed voice quality, there is decreased breathing, decreased quality of breathing. They need numerous doctor visits. They are being performed countless invasive operations. And of course, they always have the concern to spread the disease to their partners and people with their close contact. We should always keep in mind that these patients are more anxious and more physically and psychologically in bad condition than us. So we should always focus on the patient and to relate with them what we call as a whole person-oriented approach. This is the picture of one of my patients. He told me that he was operated for more than 70 times, beginning from early childhood. So we should try to focus on addressing the disease factors, medically and surgically managing the disease, and of course, providing psychosocial support to our patients. Thank you very much for your attention, and thank you very much for being with us at the UEP Voice Marathon. I hope you will enjoy the rest of the day. Thank you.